Dale had just taken a bite from his gutbuster burrito when the alerts went off. Incredible Hulk style combative. Alright, welcome to episode 6 of our podcast. Thank you for being here with me. Today we're going to do something a little bit different. I know I've been ranting a lot lately, and I don't want everything to be all negative all the time. So we're going to talk about an interesting topic that I think is worth talking about. But before we get into it, just a quick disclaimer. This podcast is produced and recorded by me. The views and opinions expressed by myself and any guests are our own and do not represent the views and opinions of our respective workplaces. This is the Rig Report. So today's topic, I have a scenario that's largely based on an actual call. I don't want to give it away here at the start. We'll get through the scenario and then we'll talk about it in more depth. But essentially, this was a call that I'm familiar with. It was something that actually happened. I've changed the names and all that to protect, obviously, patient information and all that sort of thing. So let's just dive right into it. It was a rainy fall day, just chilly enough for a jacket. Our story features two partners, paramedic Dale and AEMT Bobby. They work for Strickland EMS in Arlen and are regular partners on 24-hour shifts. Strickland EMS covers a first due population of about 8,300 people and a second due area with around 50,000 people. Dale and Bobby had just gotten lunch from Poncho's Mexican Buffet, and Dale had just taken a bite from his gutbuster burrito when the alerts went off. The call was for a single vehicle MVC. Dispatch further reports a male patient in his 40s who is unresponsive. They quickly make their way out to the ambulance parked in the lot, and their response time from the current location was about 6 to 7 minutes. So I want to stop here for a second and just talk about what are we going to expect here. So we know it's trauma related. We don't know how bad by the dispatch information. We haven't heard anything about rollovers or other vehicles involved. All we know is there was a crash and a male patient unresponsive. So obviously the first thing we go to is, this is probably trauma related. But as we all know, there can be multiple things wrong. It could have been that he passed out that caused the wreck. From what we don't know, maybe he had cardiac issues. It could be hyperglycemia, which is, a little more unlikely because it's usually not sudden onset. He could have had a seizure. We're talking strokes. It's possible. Lots of things here. But as far as what I want to know, I'm going to get ready to get a set of vital signs pretty quickly. And I'm going to want to know what a blood sugar is. And pretty rapidly after that, I'm probably going to want to know what the cardiac rhythm looks like and those types of things. So those are all things I'm going to be prepared to do fairly quickly, as well as assessing the scene and trying to look for, if there's witnesses or any of that. So a pretty good plan in place to start with to see what is going on with this guy. So moving on. Paramedic Dale mutters quietly about his burrito getting cold, while AEMT Bobby focuses on navigating through the crowded afternoon traffic. They arrive at the scene, noting a vehicle sitting upright on the sidewalk. Upon exiting the ambulance, the pair note that the vehicle has hit another parked car and several posts and signs on the sidewalk, and has now come to rest in its current location, half on the sidewalk, half on the roadway. Upon exiting the ambulance, the pair noticed two police officers, one on each side of the vehicle, attempting to speak to the patient. The officer from the driver's side approaches and reports that the patient is very confused, mumbling, and really doesn't respond to their voices. He adds that the smell of marijuana is very strong in the vehicle and expresses that he believes the driver may have taken other drugs. He is the only victim of the crash. The pair approach the vehicle, one on each side. AEMT Bobby opens the driver's side door and begins to assess the patient. Paramedic Dale opens the passenger side door and sets down the vitals bag to begin getting vitals. The initial assessment shows no noticeable trauma or life threats, no facial or head trauma, no blood that they can see, no tracheal deviation. The patient is pale, cool, and diaphoretic. He doesn't respond to a pinch on the arm other than just to grunt and kind of move his arm in the direction of the stimulus. Paramedic Dale begins to get a set of vitals, including a blood sugar. Now, I just want to stop right here for a second. So, something that I've taken in the past was called AMLS, or Advanced Medical Life Support. And if you've not taken that class, I highly recommend it. So, it showed me some things that I didn't know, and it also showed me some things that I guess I knew, but I just didn't know I knew, if that makes sense. Basically, it's talking about differential diagnoses, I suppose. And it helps you better collect the information and, what to do with it, how to organize it. So essentially, we've got a set of symptoms, and I mean, we can't necessarily rule a lot out just yet. We can't totally say at this point with the information given that the problem is not trauma related, but it's a safe bet. And here's why. A little bit more information. There was very light damage to the parked car that was hit. There's light damage to the vehicle that the patient is in. The posts were small, those little tiny, like bended metal posts, and they hadn't really caused much of an impact. And then when they sweep the patient, the initial first impression and initial rapid assessment, there's no bleeding or any evidence of trauma. So it's a safe bet that it's not trauma related, but we can't completely rule it out because we haven't looked at the abdomen or the chest yet or any of that. Now what's more likely here is a medical condition, and then we can run down the line with those given signs and symptoms. We can say cardiac issues. If it's an MI, it'll cause pale, cool, clammy, sweaty, and unresponsiveness. If it's and it's sudden onset. If it's obviously lethal rhythm, will cause those things. Hypoglycemia. If the person had an aneurysm, or there's a lot of different things that we can, at this point, we can't rule out, but it's in the back of our minds. So if you get the opportunity to take AMLS, it's taught through NAEMT. I'm going to leave a link in the description of this video just so you can visit the website and check out the class. If you get the opportunity, definitely worth taking. So let's get into the vital signs. So patient's obviously not responsive. The vital signs that paramedic Dale gets, BP is 88 over palp, SpO2 is 93% on room air, respirations are around 14 and a little shallow, pulse is 54, skin is pale, cool, sweaty, diaphoretic, and blood glucose is 38 milligrams per deciliter. So at this point we can pretty safely say that the primary issue for this patient is hypoglycemia. The associated vital signs kind of confirm, because with hypoglycemia you're going to have the low blood pressure. In this case it's 88 over palp. SpO2's a little bit low, probably because of the lowered circulation. Pulse is a little slow. He's at 54. Pale, cool, diaphoretic, or sweaty skin. All of those signs and symptoms, and the unresponsiveness, of course, goes with hypoglycemia. So now, here's where we run into a decision. Okay, um, could you give glucagon while still in the vehicle? Absolutely, you could do that. But this crew, there's an AEMT and a paramedic, both which are capable of starting an IV, giving dextrose IV. Um, in my personal opinion, and of course you're allowed to disagree. People disagree all the time, and that's fine. But here's my reasoning behind why I wouldn't do that first. So um, I'm capable of giving dextrose, and I wouldn't want to do both. So had I went ahead and give the glucagon and then got the patient in the ambulance in this case, and then turned around and pushed dextrose, there's a possibility that we could have sent this guy's glucose level to the moon, right? So you might disagree, and that's fine, but it's not my first go-to. It's not something I would have done. And then when we get into this, you'll see that that's not what happened in this case either. But if it was a BLS crew and that's the only option you had, sure, go ahead and give the glucagon there in the vehicle. That's fine. So moving on, basically what happened, the pair discussed starting an IV in the vehicle. However, due to the tight space and the unpredictable movements of the patient, they decided to get him into the ambulance before attempting an IV. The patients moved from the vehicle to the stretcher, loaded into the ambulance. Once inside, AMT Bobby begins an IV attempt, while Dale quickly gets a 12 lead. The patient has become slightly more awake, but very confused, and becomes combative. Dale has to help hold the patient's arm so Bobby can start the IV. Once the IV is in place, the pair push D50 or dextrose 50% through the IV. Now, keep in mind at the time, the protocol for this agency really didn't say anything about using D10, D25 as a drip or any of that. They're still using the D50 or half or whole kind of thing, 12.5 or 25 grams of dextrose. And because the patient was so bad, they ended up giving the full D50. So after a few minutes, the patient's blood sugar is checked again. It's now reading 235, and a line has started to help with the blood pressure, the hypotension, and they begin transport to the hospital. So on the way to the hospital, they notice that the patient has become no more responsive, but more combative. In fact, Incredible Hulk style combative. So he still not able to talk to you, mumbles and stuff in response to stimulus, but very flailing arms around, ready to fight, swinging at the provider, and remains this way through the entirety of the transport, even after his blood sugar has risen to in the 200s. So at the end of this, of course, on the patient outcome, the patient's discharged something like 8 hours later, I believe, according to the outcome, if I remember correctly. He's able to go home. They deal with the problem in the hospital. The problem is, why? Why do you think that the patient remained very symptomatic even after dextrose was given? Now, personally, I've seen this happen a couple of times now. I actually had a patient a while back that I gave dextrose to, actually got their blood sugar up to, close to 200. And this person, they were more responsive, able to talk to me, but still very confused and stumbling and all of that. So why do you think, even after you get the blood sugar to where it needs to be, why do they remain this way? Okay, so to answer this question, we have to go back to our A and P and do a little bit of a refresher here. So we know that the brain uses decent amounts of glucose out of the system. It's one of the more demanding organs in the body. or demanding parts of the body when it comes to glucose. So we know glucose enters the brain over the blood-brain barrier, and the brain is very dependent on it. The brain is not able to store significant amounts of glucose, so it requires a continuous supply from the bloodstream. Obviously, if that supply dwindles within the bloodstream, the brain is going to start suffering. And what it uses it for, essentially the brain has several energy demanding processes. One of those is essential to cognitive function, which is basically the communication between neurons. That's how the brain communicates, or it's used in the process of communication from different parts of the brain to different functions. So a study was done, and this study, I'm going to leave links to different parts of it in the description. Definitely worth the read because they discovered some really interesting things. And this was basically posted on the National Institute of Health website. But if you're interested in it, I'll leave the links in the description. But essentially what they did, somewhere around 2013, this article was written based on these studies. And what they found is typically, on average, the cognitive tasks and function begins to deteriorate somewhere around 54 milligrams per deciliter for your glucose level. Now that's on average. And typically, when we respond as EMS and we get there, it's already went to like 20s and 30s level by the time we're called. But typically somewhere around 54, according to the study, is when they've determined that cognitive decline really begins to become noticeable. And what's really fascinating is people who suffer from hypoglycemia, more specifically individuals with type 1 diabetes, usually have 2 episodes of self-treated hypoglycemia per week. And that's really interesting because we don't run that many calls for hypoglycemia, especially not when you consider the number of diabetics that are out there today. So that kind of tells us that usually those people kind of feel that coming on. They know it's about to happen, and they'll self-treat. They'll, those little rescue tablets that you can take, glucose tablets, or they'll go eat something, and they can tell when one of these spells, quote unquote, are coming on, and they'll self-treat and deal with it. It's usually only when they're overwhelmed and not able to self-treat is when we come in and we have to do something about it. But that doesn't actually answer the question of why it took so long. So deeper into the study, they find out that the impairment of cognitive function obviously is reversible, but sometimes recovery can take between 20 to 75 minutes before they completely restore their original cognitive function. And more often than not, when we treat these patients, we're in the 20 to 30 minute range, and we see them recover fairly quickly. And, they're starting to talk to us again. They're able to function more like normal. But on rare occasions, you get that hour to hour and 15 minutes of recovery time before they actually get back to their normal place. And a lot of that has to do with a couple of things this study dives into. It's called the hangover effect. And this hangover effect essentially is named because of the length of time it takes for those functions to come back or to resolve. Now, one interesting thing they did discover is that when they're in that transition phase, kind of coming back from the hypoglycemia symptoms, a lot of times speed is sacrificed for accuracy. And we can actually see this when we're talking to someone who is coming back from their unresponsiveness. They'll speak slowly. And it's almost as if they want to make sure they get the words out correctly, so they'll sacrifice normal speed for accuracy. But one of the very interesting things that this study found was that in many times that hangover effect, or the length of it, is very dependent upon a couple of different factors. They show that people who suffer from pretty bad depression sometimes will take longer to recover, and the big one is the more hypoglycemic episodes they've had, the longer it will take them to recover. So, for instance, the people that they did their controlled group, they noticed a trend where if they had had hypoglycemic episodes recently, their cognitive function was slower to be restored. Whereas the group that hadn't had an episode within a year or longer recovered fairly quickly. So that's a very interesting finding, especially for us pre-hospital, because some of the questions, and I've learned from this study, something that I might start doing now is when I'm gathering history, if there's someone nearby, like a family member or something like that, that I can get that information from, that's definitely something I want to ask. So, because it's going to give me a window or a little opportunity to find out if we're going to hit that slow to recover rate. And in the case of the scenario, this patient had several hypoglycemic episodes within the last 3 to 4 months. So that definitely had a bearing on how long that hangover effect lasted. So there's the answer to the big mystery, and I hope you enjoyed this as much as I enjoyed looking it up. It was a very interesting study and finding for me, and it will likely change how I'm going to start doing my patient history and gathering information, because it's going to give you a small insight into what's about to happen when you're treating these types of patients. So I hope you enjoyed it, and make sure you click like and subscribe, and make sure you follow to catch our next episode. As I said at the beginning of this video, my new podcast setup should be here soon, and the quality is going to improve. I'm pretty excited about it, and I think it's going to make things go a whole lot smoother. So make sure you tune in next time for our next episode. Thanks for sticking it out with me and tuning in. I'll see you next time.